Welcome everybody to our TIF Talk Tuesday. I'm Andrea Millers and I'm with Endogastric Solutions. We're very happy to have you here today and we're very excited about our special guests that we have. First off, I'd like to introduce Dr. William Barnes. Dr. Barnes is the Chief of Surgery and Trauma Director for Livingston Hospital and Healthcare Services in Salem, Kentucky. He's a board certified physician and a member and fellow of the American College of Surgeons, and also a member of the Kentucky Medical Association, Southern Medical Association as well, and a member and fellow of the Southeastern Surgical Congress. He's also a member of SAGES. He's performed, listen to this, almost over 800 TIF procedures since 2008, and we're very, very excited to have you here today. Dr. Barnes, welcome to our TIF Talk.
Thank you very much. Thank you.
You're welcome. We're also excited to have two of his patients here with us today. We have Savannah Jones. Savannah actually is a nurse at the hospital where Dr. Barnes operates, and she's had her TIF procedure for almost 3 years. Welcome, Savannah, and thank you for being here today.
Thank you for inviting me.
Thank you. And last but not least, we have Kim Preston. She is also a nurse, or has been a nurse for the last 30 years. She's in the industry, medical industry, and she actually worked for 7 years at a heartburn treatment center as a coordinator there. So a lot of experience treating and understanding GERD and heartburn. And she just recently had her TIF just 8 weeks ago, right?
Yes, thank you for having me.
You're welcome. Thank you for being with us today. So this is a very special TIF Talk today. I know that a lot of you that are watching love to be able to ask questions to Dr. Barnes or whoever the physician guest is. So in addition to that, if you have any questions for our patient guests, please feel free to ask your questions in the chat box during this live event, and we will do our best to answer all of the questions for you guys today. So we're going to go ahead and get started. Again, thank you for being here. And Dr. Barnes, let's go ahead and start off talking a little bit more about GERD and acid reflux. Can you please tell us a little bit and do an explanation? I think you have a whiteboard there, so I'm not sure if you want to get up right now and
I do.
Head to the whiteboard and kind of give us an explanation of what is GERD and acid reflux.
So, if you all can see me.
Yes.
Acid reflux is, of course, very common, as you know, and it's pretty straightforward. And this is what I tell all my patients when they come in. If I draw this really for them on a piece of paper, it makes it very clear for them. And so, acid reflux is a condition where the material in your stomach rolls up into your esophagus. So normally, when the Lord made us, he made a esophagus. That's what that's supposed to be. And then this would be your stomach. If you've ever seen the GERD video, this is about what it shows. Here's the diaphragm. And we would all have reflux because the Lord put a negative pressure in our chest in order to make this lung expand. Every time the chest expands, the diaphragm falls, the lung expands, the air goes into the lung, and then when it contracts, it goes out. And so if I stick a needle in your chest, you'll actually hear the air go in there. It's a negative pressure. The lung will collapse, and you'll have a sucking chest wound. And you'll actually hear the air doing that. If I stick it in your belly, it's still negative, but it's so much less negative that it's negative, but it's so much less negative. It's almost a positive gradient. So everything would have a tendency to go up, but it doesn't, because the size of this defect in the diaphragm that the Lord made. The diaphragm's like a parachute, a big muscle that goes up and down in the chest, and the only connection to the abdomen between these two cavities is around that defect. And so he made a certain size for around the esophagus, that size. He made a distance between the diaphragm and the stomach. He made a particular angle here, which is called the angle of His, and he put a valve here. Well, all those complicated mechanisms are what prevents us from having reflux. And people that have reflux, the problem is usually related to this junction sliding up and down into the chest. If you can imagine me drawing this little business here, this being your stomach now. And this diaphragm, this hole, being bigger. And so this junction, which is here, now it's up and down your the vocal cords that are up on the top there, and then when the material goes through it, it goes down into your lungs, and you can drown, you can get aspiration, you can get pneumonia. And so that is typically how I explain this to the patients. And when I'm talking about this, most of them have had those symptoms. They can feel that happening. And when that does occur, occasionally, these cells here are squamous cells. These cells here are columnar cells. And so when this chronic reflux happens, these cells don't like it. They're not made for it. And so they mutate. There's a high cell turnover right here, and they mutate. And when they mutate, they try to become stomach cells, but they're abnormal. And we call those Barrett's esophagus. Now, Barrett's is a pre-cancer condition. Now, not everybody with Barrett's gets cancer, but everybody in the world that ever had adenocarcinoma in the esophagus, 100% of them ever in the world had Barrett's esophagus, and 100% of them have reflux. So we think that reflux causes that. And as a matter of fact, the original operation done by Dr. Nissen back in the 50s was to try to treat that Barrett's esophagus. And we found with time that once those cells mutate, they don't change back. They stay and become, go on to, if you live long enough, to become cancer of the esophagus. And so cancer of the esophagus is a miserable condition that people live a miserable life. Even the treatment for it is miserable. So it's much better to try to correct all that before that happens. Believe me, it's much better. Once you've corrected the reflux, we think that it doesn't occur. So
Fantastic.
I think that's really about the explanation of that.
That's great, Dr. Barnes.
Okay.
Thank you very much.
You're
if
welcome.
you want to come back, as you're coming back, we'll kind of hear a little bit more from Savannah and Kim.
Could you see
a
that?
Little bit?
Yeah, you can see it. Good.
Yeah. So Savannah, can you tell us a little bit more? Tell us a little bit more about your story. You had the TIF procedure almost 3 years ago. Tell us kind of what types of symptoms that you were feeling and before you had the TIF procedure.
Well, some of the symptoms I had was nausea and vomiting all day, every day. I was weak and I just felt drained, and I just couldn't go out and do anything because I was so sick all the time.
So were you sick? Did you have other symptoms aside from feeling sick? Did you actually have that heartburn feeling, or you would just get sick after you eat certain foods?
I would have the heartburn feeling pretty much all day long, and anytime I ate, I would end up getting sick.
Okay. And were you taking any medication to help you with your reflux or acid reflux?
Yes, I was taking lots of medicine. I was taking about 10 to 12 pills a day. And then on top of that, Tums, just to help control it during the day.
Wow. And how long have you been suffering from Gerd?
Well, since I was born, I have been suffering with acid reflux. And so it just, over the years, it got worse and worse. And finally, I just couldn't handle it any longer.
Okay. And you actually work there with Dr. Barnes, and your mother does too. And she knew about the TIF procedure. And so when you actually turned 18, you already knew that that's what you wanted to do. Is that right?
Yeah, she's actually been with Dr. Barnes the entire time he's been doing it, so she's seen it all and could probably do the surgery in her sleep.
Oh, wonderful. Kim, so tell us more about your story. It's a little bit different. Tell us what kind of symptoms were you feeling? How long have you been suffering with GERD? Was it the typical symptoms that you felt?
Yes, just the common symptoms like acid reflux and heartburn. I've suffered with that for many, many years. I can remember when I was pregnant with my daughter, I had such severe acid reflux that I would actually get a bottle of Maalox or Mylanta, get it cold in the refrigerator, and set it at my bedside at night. Another symptom that I had was I could drink something really cold, like a shake or a smoothie. And I noticed one day I took a deep breath and I could actually feel the smoothie come up all the way back up into my mouth. That scared me a little bit. I was also having like chest pain. The chest pain that I had really concerned me. When you have GERD, you sometimes you can expect to have chest pain if you have a esophageal spasm. What concerned me was my chest pain actually radiated to my left arm, and as a nurse, you know that could potentially be cardiac. And one of the follow-up appointments I had with Dr. Barnes, I mentioned that. I told him that, previous to having surgery, I was having chest pain and shortness of breath. And he told me that over half of my stomach was in my chest and it could possibly be competing like in the same space. So yeah, so after surgery, I've not had any of those symptoms.
Wow. Wow. And you're 8 weeks out, correct? Since
Yes.
your surgery. Okay.
Yes.
Fantastic. Thank you for sharing that. We'll ask you more questions about your journey, but Dr. Barnes, maybe you can kind of talk a little bit more about what are the different options, or what do you typically recommend for patients that are suffering from GERD, even before surgery or the TIF procedure? What types of things? Are there lifestyle modifications? Are there activities that they should minimize? What are your thoughts?
Do you mind if I go back to my board? Would that be
Oh,
okay?
sure. We got visual
So,
aids today.
yeah, we're lucky, aren't we? So,
Yes.
normally the first thing that we try to do, because you can see it's a defect here with things sliding up and down in your chest. So we try to tell you to go to bed on an empty stomach so that this food doesn't roll up into your chest at night. We ask you to raise the head of your bed so gravity will pull these things down, and the bed has to be not in a straight line. It can't be bent like you would with a chair. It has to be in a straight line. And that gravity then will keep the food down in the stomach. So we try to do that. And if you try, we also ask you to take what's called a PPI, which is a proton pump inhibitor. And those things this will stop the acid in your stomach so there'll be no acid reflux. Now you still reflux bile and you still reflux debris. And so the risks of Barrett's actually doesn't change or may even go up, but there's no other pill that we can give for that. So that stops the acid and it stops the pain and discomfort. And so we try to do that for a reasonable amount of time. And if we do that, people that have reflux, some of them have it very light, some of them have it very heavy, some of them are here in the middle. And so if you all do this, raise the head of your bed, go to bed in an empty stomach, take the PPI, that shifts the curve this way slightly so that it might be like this now. Instead of half the median being there, the median may be here. And so these get better, but they don't, the ones that are severe still are in danger of aspiration, pneumonia, and all those things, even though we've changed the physiology of what's going on. And you can actually even also go to the chiropractor, and the chiropractor can do a maneuver that actually pulls the stomach down into the abdomen, but it doesn't really stay there. It eventually goes back up into the chest. So that doesn't cure it in any way. And none of these things really cure it. If you can lose weight, you can take the medicine for a short period of time, raise the head of your bed. You might be able to shift that curve and improve your symptoms. But most of the people that I see have been doing that for years and years and years, and they don't get better. And this medicine, the PPI, if you go to the store and you buy it and you look at the bottle, it'll say, don't take it for any more than 2 weeks. If you go to the doctor, they recommend us not keeping anybody on it for more than 2 months. And most of the patients I see have been on it for like 10 years. And this medicine is a pump inhibitor, which means it inhibits the proton cells in the stomach from pumping out the proton, hydrogen, to connect with the chloride to make hydrochloric acid, which is the acid that people feel.
Right.
And well, that proton pump inhibitor affects every cell in your body, and the proton pumps in other cells have different functions. And the cells that line the blood vessels that go to your heart and your eyes, your kidneys, your brain, those proton pumps pump the garbage out of the cell. And so when the garbage doesn't go out of the cell, it builds up in the cell and they die early. We call that early senescence. And so that we think that may be the reason that there's so much higher incidence of Alzheimer's disease, heart disease, and kidney disease in people that are taking that PPI. And I have some of my patients that are referred to me by the nephrologist because they want to get their patients off that PPI because they're in renal failure. And so it is not a safe medication, although you can buy it anywhere over the counter, and so that makes people think it's okay to take, but it's really not, because not only does it do that, like I said, it takes the acid out of your stomach. That acid was put there for a multitude of reasons: absorption of calcium and minerals and functions in your small intestine that now are not being done because there's no acid in there. And so we think it may even be the cause of chronic fungal infections, and there's a new entity, or an entity that's been out there for quite a while that we're just figuring out. It's called small intestinal bacterial overgrowth, or SIBO. And we think that may be the participant that starts it, the PPI. So,
wow. Well, thank you. We really appreciate that explanation. Savannah, I know you told me one time a story about having to put bricks under your bed when you were suffering from GERD really bad. Are there other things that you had to modify your diet? Were there certain things you couldn't eat, or things that you remembered? I know it's been 3 years since you had it, but were there things that you're like, oh my gosh, I had to do this because I can't live with this GERD?
Well, yes, I had actually 2 bricks under each side of the head of my bed, and it was raised up pretty high. And then I wouldn't eat anything after 7 o'clock, so I could make sure my stomach was completely empty before I went to bed. I couldn't eat anything spicy, nothing with acid. I couldn't even drink orange juice and anything like that. And even sometimes water even bothered me. And so I love pizza now and spaghetti because I can actually eat the tomato sauce.
That's wonderful. And Kim, what about you? Were there certain things that you had to modify as you were trying to work through and before you had the TIF procedure?
I didn't elevate the head of my bed, but I did sleep on 2 pillows at night. And I did get a little bit of relief. As Dr. Barnes was showing you the anatomy, I noticed that if I slept on my right side, I would have more reflux. And if I was to move over to my left side, I would have less reflux.
Okay.
But I would have it so bad at night that it would just take my breath away.
That's crazy. So let's talk about, well, you know what? We actually have a few questions that have popped up. If you don't mind, Dr. Barnes, they look like or some of them are. We have a question from the audience. What diagnostic testing is required for the TIF procedure?
Well, typically what I do on everybody is first, talk to them and examine them to see if their symptoms really are reflux, because sometimes people can be confused and think they're having reflux and it could be something else. So then after I've done that, and if I feel that that's their problem, then I would schedule them for a barium swallow, which is an X-ray that you swallow barium and it shows the function of the esophagus. Then I'm going to go back over to my paintings here for a minute.
You could just stay there if that's easier, Dr. Barnes.
No, I like the movement actually. So anyway, so then I schedule them for an endoscopy, and I look down there. I can look at their vocal cords to see if I see inflammation there, and then I look esophagus and look for Barrett's esophagus, because some of them have Barrett's. Then I come into the stomach and I biopsy the stomach for infection to make sure they don't have H. pylori. Then I look at the duodenum, make sure they don't have an ulcer, because sometimes the symptoms are very, very similar. Then I take my scope and turn around and look back up at this hole here. I try to measure that hole. I do a maneuver called the Selleck maneuver, which is an anesthetic maneuver that anesthesia does on emergency cases so the patients don't vomit while they're putting them to sleep. And that maneuver is very simply putting pressure on the cricopharyngeal cartilage, first cartilage on below the larynx, and putting it pressure straight back on the spine that holds the air in the esophagus. And so when we insufflate the stomach, while I'm back looking up at that, I can actually measure the exact diameter of that defect. And that'll tell me whether the patient can have a straight TIF or has to have the repair of that diaphragm. And then I put a special, at the same sitting, and same endoscopy, I put a catheter in their esophagus and measure how well it functions to make sure they don't have a motility disturbance, which for the TIF isn't as important as it is for a Nissen. If a patient has a motility disturbance and you do a Nissen, it could be devastating for them. Whereas in the TIF, because it's not a 360-degree wrap, which we'll show later, it's not as worrisome. However, there is an entity called achalasia that you cannot really see, that can only be measured by barium swallow and by manometric studies to prove that they have that. And that is a complete different operation that needs to be done. A TIF can be done later, but it can't do it all at the same time. Can you all still hear me?
Yes, we can hear you.
So, and that is number of reasons that happens. Could cause from a virus, can cause from trauma, can be caused from diabetes. It can be caused from this hernia sliding up and down against that ridge of diaphragm. It can injure the nerves to the stomach, and it can injure the tiny, very friable nerves in the end of the esophagus. And when they get injured, that muscle won't relax, and food goes down and stays there. It won't go anywhere else. And because those nerves cause the muscle to open and close when food gets there. So if it doesn't ever open, then food builds up in here, and it acts very similar to reflux. So it's very difficult to know that, and you have to do that with it. So we do that at the same time. Then we put a capsule right here in the middle of the esophagus, and it measures how much acid is actually coming up. When acid hits it, it sends signals out to a little box that we have the patients wear, and they take that home with them and wear it for 2 days, and then they send it back, and then we download it on our computer, and we can actually see how well what their acid function is, and that proves to us then we have all this information that this operation will help them. If it doesn't, we don't have all that information, we don't want to do that kind of surgery on them. So we're very careful with that, and that's the kind of workup. And we do that all at one sitting. It used to be we had to do each one in several times, and it took months. Well, now we can do it all and get it done within a 2-week period of time. And by the time the patient comes and is evaluated, within a couple of weeks, we know whether we can operate on them or not, and then we can schedule them to surgery at the patient's convenience. So technology has really helped us in this regard.
Fantastic. Thank you. So Savannah and Kim, tell us a little bit about what you did. I mean, I know you have a little bit of an advantage because you guys are both nurses, right? And you're kind of in that space for Gerd, but where did you get your information to make the decision of getting the TIF or any decision on moving forward? I'll start with you, Savannah. I mean, I know you were just struggling so much. What type of research did you do? Did you talk to just Dr. Barnes? Did you go on websites to get more information? Where did you get most of your information from?
Well, working at the hospital where he does the procedure, I talked to a lot of actual patients that had had the procedure, trying to make up my mind. And I also talked to Dr. Barnes, and I went to gerdhelp.com website and read anything I could. And I just Google on the internet TIF procedure and see what popped up before I made my decision.
Okay, fantastic. How about you, Kim?
Well, that was actually my area of expertise because I was the nurse coordinator of a heartburn treatment center, so I knew all about it. I knew about the workup, and actually, I've been through the workup. I had the esophageal motility, which showed that I do have a motility issue. I had the 48-hour Bravo pH study where I wore the recorder home, and it actually came back very, very positive. And, you know, I'm just aware of GERD and what it can do, you know, the side effects.
Sure. Sure. Thank you. So let's get to it, Dr. Barnes. Why don't you tell us a little bit, before you go into the TIF, can you talk a little bit more about what are the different treatment options for GERD today?
Sure. There's, besides medical treatment, which is, you know, keeping the head of your bed elevated, there really is a surgical problem. I mean, it is most of the time an anatomic defect. The loss of that angle of His that we talked about, it's a loss of the valve. It's the dysfunction of the diaphragm where the stomach comes, that negative pressure pulls that up there. So all these other forms of non-surgical treatment can help some of the people if they have mild disease, but for the most part, it is going to end up with a surgical repair of some sort. In the 50s, Dr. Nissen, because of the Barrett's esophagus was such a devastating problem, designed the Nissen Fundoplication. And that worked very well as far as the reflux. It did not stop the Barrett's, but everybody that has had that operation can never, even every patient he did, every patient I've done, every patient that when it's done appropriately, it's done correctly, those patients cannot belch or vomit. If they can, there's some dysfunction of the valve. So something's happened that it's not working correctly. And so those patients cannot belch or vomit. And there's been several, because of that, it's a big problem. There have been many operations that have occurred to try to correct that. There was something called the Belzy that was done through the chest. Well, that fell through the wayside because doing a thoracotomy on all those patients was so devastating that it didn't work out as well. And it didn't work as well functionally. And there's a thing called a toupee operation, which is a 180-degree wrap to try to allow the patients to still belch. There's an operation called a door fundoplication, which we use mostly for different indications. But none of those ever worked near as well as the Nissen. And the Nissen worked. But the problem with the Nissen was that you couldn't belch or vomit. And if you put 100 patients that have had that operation in a room 3 years later and ask them after they've gone through their reflux has stopped, and you put 100 of them in a room and you ask them how they're doing, 30 of them will say they're doing great. 70 of them will come right out and say, hey, I wish I'd never had this operation. I'm belching all the time. I can't belch. I can't vomit, and I'm farting all the time. I can't even go to church. I bend over to pick up my Bible, and it's very embarrassing. So I'm stuck in the house. And so 70% of them are very unhappy. Whereas you take 100 patients that have had the TIF and you put them in a room 3 years after they've had it, 5 years after they've had it, 10 years after they've had it, and you ask them how they're doing, most of them will all say, yeah, I'm doing great, no problem, you know, and then you wait for anybody to say, you know, I wish I never had that operation. And nobody says it. Zero, none. And so in no terms of that, I think it's a much better operation. And also the failures are usually not related to the TIF, it's to the diaphragm, that hole in the diaphragm that we sew. And it isn't that the sutures break, it's that the muscle is tears because of some other trauma, lifting heavy objects inappropriately or getting in another car accident or some kind of thing. And so my personal opinion is that the Nissen causes more of that disruption than the TIF in my own observations, because patients are not having that retching that they can't vomit. And so, and that retching tears the diaphragm. So we don't see that as much. And in the last few years, trying to avoid the Nissen Fundoplication, many different operations have come about. The TIF was one of them, and it mimics the Nissen in all anatomy and physiology and function and science. It fits it exactly what a Nissen does, but it doesn't have those long-term complications. There was at a time that they did an operation called the Strata, where they put this balloon into the esophagus. It had electrical probes, and they would hit it to an electricity, and it would cause scarring, with the idea that the scarring would help prevent some of the reflux. Well, that's fallen out of the wayside, used very rarely now for other indications, but for reflux, generalized reflux, it's not effective. And there's also another operation out there that has been recently come called the Lynx, which is a set of magnets that goes around the esophagus that is hooked to there, so that when a bolus of food goes through there, it opens up and then closes, and opens up and then closes. And supposedly that's supposed to help it, but it doesn't follow the physiologic issues that I've seen. It's a foreign body. My own personal opinion, after being a surgeon for 40 years, is in the very beginning, we put out, when we were doing this back in the 80s, another device was placed around the esophagus called the ancillate prosthesis. And many of them, surgeons my age, remember that and are very reluctant to put a foreign body around the esophagus, because we've had to take out just about all of those that eroded into the esophagus or fell down into the pelvis, or it was a devastating issue. So I don't really know that the answer for that one is out yet. Studies are so far in the last few years look like it's promising, but I don't think it compares to the TIF, in my opinion.
Fantastic. Thank you for sharing that with us. Why don't we go ahead and you have a famous towel talk that I think everybody that's watching will love to see. So I don't know if you're going to do it here or in front of your.
I'm going to go over there.
Okay. Yeah. This is a great way of explaining what the TIF procedure is. And so we'll let him do that.
So I hope you can see this. This is.
Yes.
Okay. So back in the day when Dr. Nissen did this operation, his idea was to repair this angle of His, to bring it down below the diaphragm, and to make a new valve there. And that operation is this. If you can see this as being the esophagus and this being the stomach. Wendy, can they see that? Mm-hmm. So we had to do it open back then, but now we can do it laparoscopically. And we go through into the abdomen, dissect around the esophagus, and pull it down below the diaphragm. If you can imagine that being the diaphragm, pull it down below the diaphragm, dissect the vessels off the lateral border of the esophagus, which their spleen is right there. And so there's some risk of injuring the spleen. Coming all the way around the esophagus to make it completely free, then grabbing the stomach from below, pulling it around behind the esophagus, and suturing it anterior like that. And that then sutures on the outside there, that recreates the angle of His. It recreates the distance below the diaphragm and recreates the valve. And so it's a 360-degree wrap, and that's why patient, if it's done appropriately, we try to make it loose. It's called a floppiness, and we know now not to make it too tight. We make it loose like that. And that, you cannot belch, you cannot vomit, but you don't reflux any longer. And that sits underneath the diaphragm. And it causes dysphagia occasionally because we have to turn it and sew it anterior. And so you can see how it kind of twists the esophagus. And that sometimes gives some dysphagia. The TIF, on the other hand, if you can imagine this being the same situation, now we might have to, if they have a big hole in that hernia, we have to repair it and sew it up so that it's the right size. We pull it down so that it's below the diaphragm, and this is where the TIF important part would come in. Recreates the angle of the hips, makes a new valve, it's below the diaphragm. So that's what the TIF plus operation would be. So if you can imagine that, and we've gone around that, pulled that down so that's below the diaphragm, then we come out, go down the mouth with the TIF device, or in patients that don't require that operation, we just do the TIF part. And it has an attachment on the inside that pulls it below the diaphragm and then folds the stomach back up on the esophagus. And lo and behold, it looks just like the other operation. It has functionally, it measures the same, it works the same, it looks the same. Years later, when you look up from below, you can't tell the difference really on many of the patients, whether they've had a TIF or a Nissen, because it functions the same. And so we have the angle of His. It actually, in my opinion, is better than the Nissen. It is the same distance. You have the valve. The sutures are on the inside instead of the outside. So it is, the healing is different and it's much more robust. And I believe that it lasts longer, works better than the Nissen, which is why I do it. And then if you look at the front, it is not 360 degrees, it's 300 degrees. So it's open and patients can still belch and still vomit, and it sits naturally we don't have to rotate it anterior, it sits naturally in the stomach. So anatomically, surgically, all these things tell me that this works better. And my own personal experience is that works very, very well. I have all these patients that come from all over the world to have this done. And they're very, 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 very happy, and it works extremely well. So that's the towel trick there.
Love it, Dr. Barnes. Thank you so much for sharing that with us. So let's talk a little bit to Savannah and Kim. Maybe you can tell us what made you choose the TIF procedure as your treatment choice, if you will. Savannah, you can go first.
Well, working with Dr. Barnes, he was always telling me about it, stopping me in the hallway, and because he's been with me my entire journey of having acid reflux, and so doing lots of research, and I did lots of research on other procedures and the TIF, and I watched many of his towel videos, and I was ready to do something because I was tired of not getting to go out with friends and eat pizza or eat spaghetti, because it's the easiest and quickest meal ever is ordering a pizza.
Right.
I was just, I'd say I was wore out because I was only 18, but I was wore out from the acid reflux and the hurt it was putting on me, and the side effects of all the PPIs. I was just scared of what the future would hold. So.
Right. Thank you. And how about for you, Kim? What made you decide to do? And I know you have a lot of extensive knowledge about it, but what actually made you decide that the TIF was the right procedure for you?
Probably personally, where I had esophageal motility disorder. I was worried that I would have difficulty swallowing. I know that the laparoscopic Nissen Fundoplication would have cured my acid reflux, and I would have had good results, but I was really worried that I would have difficulty swallowing and the gas bloat syndrome that a lot of people complains about. And working with Dr. Barnes 2 or 3 years ago, he told me how successful and low risk was the TIF procedure, and minimally invasive. So that was the route that I wanted to go with, and it's done very well.
Fantastic. Now I understand that you did not take, as you were afraid of PPIs, especially because of all the information that you knew. Can you share that? Share what you know, or what your thoughts were on it, and why you didn't take PPIs as a treatment option?
Sure. There's a lot of controversy. If you Google PPIs, or if you read a lot of articles, some of the side effects, potential side effects can be like osteoporosis, Alzheimer's disease. It can affect your heart. Like Dr. Barnes said, it can affect your kidneys, multiple side effects. So I chose not to go that route. If I ever had to take anything, I felt comfortable taking Zantac. And as you know, just a few months ago, they actually took Zantac off the market. I've also, at night when I had really, really severe heartburn and reflux, I would actually get a glass of water and put baking soda in it.
Wow.
And I was just concerned about the side effects and the long-term chronic use of PPIs or stomach medication.
Right. Thank you. So tell us a little bit, Dr. Barnes, about the recovery process. How long can a patient expect to be in the hospital? How long does the actual procedure take? And what can they expect after? And I know maybe you want to touch a little bit about, if they're having a combined procedure, a hiatal hernia repair and a TIF procedure versus just a TIF procedure, and what the difference of that would be.
Well, really, typically the hospital stay is overnight. I mean, they come in, and there's some of those patients that feel like it's sent home that day, but I have people coming from a long way away, and I'm reluctant to send them that far away without making sure everything's good. So I typically keep them overnight, and they go home the next day. The next morning, they're usually on Tylenol or maybe a small narcotic that I may give them for 3 days maximum, and then they go home. And the difference between the two procedures, really, the patient can't tell. I mean, the laparoscopy is so benign as far as pain goes. It's technically, demanding, but we use a long-term local anesthesia, and it takes about 3 days for those wounds to get back into feeling. By that time, they're pretty well. So really, the patient doesn't know much difference between the two operations. I'm the one. I mean, I have to spend more time doing one more than the other, but typically they don't. And then they go home for after a day or two. Sometimes, I don't know, Kim, did I keep you more than 1 day? Did I keep you 2 days? Because she lives like 5 hours away or something. I can't remember. Did I keep you more than one night?
No, actually, you wanted to keep me 2 nights, but when you come in at 7:30, I was already up and ready to go home.
Yeah. If she look, if they look like they're just doing great, I will tell them that. And then, of course, I actually give those patients that live far away my cell number so that they can call me if there's a problem, and they never call me, so I guess there's no problem. So then in about a week, they really get back to you'll ask these girls how they were. I mean, they're really, in a week or so, they're back to doing what they were doing. They just not allowed to lift anything over a gallon of milk for 6 weeks. They're on a specific diet, not liquids, but baby food consistency for 6 weeks. And after 2 weeks, we add a little more things to it. And then I don't allow them to lift, and I really don't like them to mow. A lot of people around here have these riding lawnmowers, and they're pretty rough with them and wild with them. So I don't like them doing that till it's really healed. But they go on to their regular business, and after 6 weeks, they're really good, and they're really happy to see me. And after about a year, they're very, very happy. And then they forget they ever had Gerd, and they forget all about me.
That's wonderful. So maybe, Savannah, tell us a little bit about how your actual procedure went the day of, and how do you feel today? I know you're quite a couple years out from the TIF procedure. How are you feeling today, and how was it for you having the surgery?
On the day of the procedure, I was very nervous. I went in with the mindset that this was going to fix everything, and it did. But I was very nervous, and I stayed 1 night in the hospital, and I would say the diet is by far the hardest part, keeping the baby food consistency. Just think baby food and think nasty, but I drank lots of protein shakes. That's what kept me going. And now, today, I feel amazing. I feel great. It's canning season around here, and I can open up a jar of tomato juice and just drink it straight.
Wow.
So I feel great, and I'm very thankful for it.
Wonderful. That's great news. And how about for you, Kim? How was your experience? I think you had mentioned you drove 5.5 hours to see Dr. Barnes and have him do your procedure. Tell us your story.
Well, it was worth it. Actually, the week before, I had to drive 5.5 hours to do pre-op and get a COVID test.
Oh, that's
So
right.
I actually made 2 trips to Salem, Kentucky, but everything went well. The morning of the procedure, before Dr. Barnes come in, like I said, I got up, I showered, I was ready to go home. I was ready to hit the road. And I didn't have a lot of pain for the first 3 days, just like he said. Um, I embraced the diet. I felt that it was a time that I could like reboot and think about how much I was eating, how often I was eating, because most of the time I'm not a breakfast eater. So I would skip breakfast. And if I was working and busy, I would not eat lunch. So in the evenings, the comfort food, that's what I would go for. And it just makes all the sense in the world. All of my symptoms I can trace back to having a large hiatal hernia and the acid reflux. So just to give a visual, if you have a large hiatal hernia, like when I was on the road, my favorite meal or comfort meal was Chick-fil-A hot and spicy chicken combo with pepper jack cheese, waffle fries, and ranch dressing for the dip. That's my all-time favorite meal. And if you think about that, I told you before that I had heartburn. And I'm sorry, I told you I had chest pain. So
Right.
if you think about the volume of food that's in that one combo meal, and Dr. Barnes told me that all of that food was in my chest that could have been causing the chest pain or the shortness of breath, I think now the implications, if I had not had this procedure down the road, what it could have meant for my health.
Right.
So I'm very, very thankful to Dr. Barnes.
Wonderful. Gosh, it's so think about. You don't, most people just eat and don't think about what the effects of the food would be in your stomach. So that made a very clear picture to me when you were explaining that. So thank you for sharing that. And your favorite meal. Is it still your favorite meal?
I haven't had it. So, after this procedure, this is the best time to sort of restructure your eating. I don't want to go back to eating large portions. Dr. Barnes, the first week you consume, he asked you to consume 1/2 cup and consume that over 20 minutes. Well, I eat very, very fast. I eat very fast. But I did notice, even in the last few weeks, I'm up to a cup of food at a time. And I could probably go beyond that now because I'm 8 weeks post-op. But if you let your brain catch up with your eating, you don't want really any more food. If you would just stick to that, if you stick to the cup and just think about it, I will do anything to prevent having acid reflux again.
So since you've had your procedure, 8 weeks ago, have you had any acid reflux symptoms since then?
No, I have not had any acid reflux. I have not had any heartburn. I haven't had any shortness of breath. I have not had any chest pain. I can take a deep breath, and the green smoothie that I love to drink, it does not come back up. So I've had a really good result from it.
Wonderful. So you went from Chick-fil-A to green smoothies since
Yeah.
the TIF procedure.
Yeah.
Wonderful. Well, thank you so much for sharing that. We do have a couple of questions. I just want to make sure we can get through them today on this talk. Someone's asking how they can find an experienced TIF surgeon in their area. So I can answer that question for you. We do have a website called gerdhelp.com, and on that website, there's a physician finder. You just put in your zip code, or you can search by state, and you'll be able to find a physician in your area. And I know a lot of people travel to you, Dr. Barnes, from all over the place, even outside. Dr. Barnes is in Kentucky, Paducah, Kentucky, right? Is that right?
Near Paducah, Salem, Kentucky, which is a
Salem.
suburb of Paducah.
There you go. Okay. So I've been out there. I have been out there.
I know
To
you.
see you. Yeah. Okay, so just a couple more questions just to make sure we answer them. Let's see. Someone was asking, how long does the TIF procedure work?
Well, I can tell you that I've done Nissens since 1975. And since I've become here in 82, all the Nissens that I've done, I've followed them. And believe me, those Nissens, which were done correctly, don't all last forever. And there's a plethora of late complications you can get from a Nissen Fundoplication. And I've been doing the TIF since 2008. And I still see those local patients that I've done. You know, they come back for other issues, and I might even have to rescope them for some reason or another, and the TIF is still intact. As a matter of fact, I endoscoped a lady today that had one back about 2010, and hers is still intact, and she's not having any symptoms of reflux. So my personal opinion is the long-term outlook after the studies show that after a year, after 6 months that it's intact, it stays. So far 3 years, 5 years, and they haven't published anything greater than that, but I personally see them all the way out, and I think it's a better, because of the way the sutures are placed through and through the esophagus and the stomach, that there's a tissue reaction that happens that's different than the other suture, so that as people get older, it doesn't just fall down and tissues fail. This stays together, and that angle of His stays together. So I think right now, I haven't seen any failures from that related to the TIF itself. Any failures I see are related to the diaphragm, either a tear or a change or a lifting issue. But the TIF itself is extremely robust, and I don't see any long-term issues related to that.
Fantastic, thank you. Next question. So there's a little bit of explanation, but the gist of the question is, does TIF work for swallowing issues? They're saying they've been diagnosed with acid reflux and Gerd for 10 years ago. Recently, I've been having issues swallowing where food actually gets stuck in my throat. It had gotten so bad I had to have an endoscopy and balloon dilation stretch because my esophagus had narrowed. That was back in May. I have to go back for another stretch on August 31st. Does TIF work for swallowing issues?
The TIF will stop the reflux. If the dysphagia, what she's describing, is from the reflux, which typically it is, because if you look back at that I'm going to go over to the picture for just a minute.
Sure.
If you look at this chronic inflammation here, this chronic inflammation, you can get ulcers, you can get edema, and as it heals, some things happen, it heals, it gets narrower and narrower and narrower, and you can get a stricture right there where the food itself won't go down in there, and that has to be dilated. That means that esophagus is sick. Now, when you fix the hernia that stops the reflux, eventually when that heals, it might have to be dilated 1-2 more times, but it should get better eventually, unless they've done it so long that they've injured the nerves in the myenteric plexus that causes them to have achalasia. Then an entire different subject happens, and that happens because it's going up and down against this diaphragm, and it's beating that mucosa and that muscle every time it does that. And that can damage the function of that esophagus. And then the TIF itself won't, for that problem, achalasia, the TIF can't help you. You have to have, that has to be done well before you develop that problem, and it can prevent it. So if she's having dysphagia, that needs to be carefully delineated to make sure she doesn't have Barrett's esophagus, that she doesn't have cancer of the esophagus. And after those two things are ruled out, then she needs to have a benign stricture, needs to be dilated, and she needs to be worked up for repair, because that means she's reflux and severe enough that she's going to have permanent problems and permanent issues related to that esophagus. It's a significant, severe problem, and people that have that issue really need to find somebody to take care of it. And the difference between a Nissen and a TIF is that the doctor doing the TIF, his reflux, his procedure is going to be essentially the same as mine, because it's an instrument, it's a tool that goes in there and repairs the thing. Whereas a Nissen, dependent upon the surgical expertise of the surgeons. Some of them are really excellent, some of them not so good. Just like anybody else, there's a bar curve. But with the TIF, they're all the same because it's a tool. It's reproducible. Everybody that does it exactly the same. And so the results are exactly the same. So my suggestion to that girl is to find a doctor that does the TIF, go to him, have him work it up, and have him take care of it. And she'll be very, 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 very happy before she develops any of the other problems.
Fantastic, thank you. One last question before we close out for the evening. We have a patient that's on here and is asking is there an age range for having the TIF procedure? She's 84, so she's wondering would she qualify for the TIF procedure at that age?
The oldest patient that I've done is 92. The 92-year-old was the family begged me to do her because she was bedridden. She couldn't eat. She had lost weight. She was refluxing so much that she had sores around her mouth. And they begged me to do it. And I thought, here's 92 years old. So I went ahead and did it. Well, 3 months later, that 92-year-old was driving herself to Walmart and pushing a cart, not driving a cart, pushing a cart because she could eat. And she lived 7 more years happy. She did not, it was the last year of her life before she was bedridden again. And she thanked me and her family thanked me. As a matter of fact, I think her daughter and her daughter's husband, both of them decided to have the TIF. She did so well. And so 84 depends on how you are. If you're a healthy 84-year-old person, it will definitely help you. And if it's just the TIF that you're going to have, not the laparoscopic procedure where the TIF itself is so benign, the risk of the TIF are less than a colonoscopy. Now, if you're 85 years old, if you'd go through a colonoscopy, you can go through a TIF, period.
Fantastic. Thank you very much. There are quite a few more questions on. Thank you for asking them. What we'll do is after we're done, we'll have our Chief Medical Officer help answer any of the questions that are on there. So if we missed it, we're sorry. We just want to make sure that we get everybody on and everybody gets to tell their story. Dr. Barnes, we can't thank you enough for all of your expert advice and your descriptions and everything you talked about with Gerd and the TIF procedure. And thank you for taking the time to be on here. And Savannah and Kim as well. We can't thank you guys enough. Is there any last comments or anything that you want to share with our viewers that are on Facebook tonight watching? Dr. Barnes, I'll let you go first if there's any last comments you'd like to share.
I have 100 things I'd like to share. I'm very enthusiastic about the procedure because it really changes people's lives. I mean, I've had so many people that have just immediately after the surgery felt better. They slept all night or they many different things, life-changing. Savannah's not talking about how she was before she had the surgery. Now she's gone to college. She's got a job. She's got a future, got a boyfriend. So she's doing, her life has really changed. And I see that a lot. People's life change. And I could talk for an hour on that. But the one thing I wanted to say is I want you to tell your chief medical officer I said hello. I haven't seen him in a long time. He needs to come see me. Okay, thank you.
I will. Thank you, Dr. Barnes. And Savannah, how about you? Any last comments or anything you want to add?
Well, like Dr. Barnes said, it has changed my life. I've been riding horses, and I'm on the lake tubing every weekend and jet skiing. I haven't gone zip lining yet, but I'm doing all the things I wanted to do when I was younger.
That's fantastic. Thank you for being on here and sharing all of that. And for Kim, how about you? Any last comments or anything that you want everybody on here to know or any advice that you have for patients suffering from?
I just advise anybody that has heartburn, reflux to see a gastroenterologist or a surgeon and have something done about it. This is a very minimal invasive procedure, especially if you do not have a large hiatal hernia. So take care of it. Do not keep putting it off and chancing having complications, such as Dr. Barnes says, esophageal cancer or anything like that.
Wonderful. Well, again, everybody on Facebook, thank you so much for joining us this evening. We really appreciate it. As I mentioned, if you need any more information about the TIF procedure or GERD treatment options, you can go to gerdhelp.com. We also have our Facebook page here and do our TIF Talks every Tuesday. So if you missed this one or want to get on the next one, it's on every Tuesday in the evening around 5 p.m. And again, thank you everybody for being on here. We really appreciate it. And everybody stay safe, and we'll catch you next time. Thank you very much. Have a great evening.
Thank you.